Thank you. I have to laugh. I think I lost the over-under in the spirit of gambling at work because I was like, wow, who's going to come back at 1:30 in the afternoon in Phoenix on a Friday? But thank you all for being here. So when I put this talk together, I put it together kind of selfishly because when we talk about traumatic brain injury, and I'm going to get this, I have no disclosures, but when we talk about traumatic brain injury, we talk a lot about severe traumatic brain injury, and there's been a lot in the press and research on mild traumatic brain injury. But as a nurse at the bedside and a nurse practitioner and a provider for people with traumatic brain injury that come into our facility, the people that I wake up at night thinking about are these people, the moderate TBI patients. So I wanted to talk a little bit more about them and opportunities maybe for enhancement at the bedside and throughout their continuum of care. So when we talk about talk and die, it's a term that was first coined in 1975. It's used to describe those patients that we've seen where they come in and they're talking to us 1 minute, you think everything is fine, and the next day you're watching their autopsy. It's used to it's for patients that we think deteriorate and die secondary to reversible causes. When it was first described, it was found on autopsy that 25% did not have a hematoma, but they had ischemia or hypoxia. And in the 1970s and even into the 80s, if you took care of patients then, we did a lot of hyperventilation. So that makes sense to me, the hypoxia and the ischemia. But a lot of them were due to intracranial hypertension, so monitoring ICPs, and it's due to swelling of contusions, which represent a special part of this patient population. So, like I alluded to, who are we talking about? We spent a lot of time on GCS 13 to 15, or our mild traumatic brain injuries. We have Brain Trauma Foundation guidelines that help us with our severe traumatic brain injuries. But we're going to talk today about those moderate traumatic brain injuries, which are a GCS of 9 to 12. On your screen, you see the Glasgow-Coma scale, and the Glasgow-Coma scale has been around from the 70s. It's the most studied tool to examine the mental status for trauma patients. It was updated last year for the GCS at 40 to have verbiage that's a little simpler to understand and more applicable at the bedside. I don't know if your facilities have incorporated it into their electronic medical record. We have not yet, but hopefully we will. So what do we know about moderate TBI patients? They're 20% of our hospital admissions. For every 22 mild traumatic brain injuries, we'll see 2.5 of those as moderate and 1 is severe. And of the moderate, 30% have a chance of having some sort of brain lesion. We'll talk about some of those lesions. 30% have a chance of those injuries progressing in volume or mass effect due to cerebral edema or hemorrhage. And 30% have a chance of worsening neurostatus or deterioration. They're mainly adults and they're mainly men involved in motor vehicle collisions, falls, assaults. We see a worse outcome if there's significant extracranial injuries are present, so if they have chest injuries, abdominal injuries. The mortality in this population is about 15%. The devastating part about moderate TBI is the cognitive dysfunction, and about half of those that have moderate TBI sustain some sort of cognitive dysfunction. Only about 20% have no significant disability. So let's talk about a case, just to kind of put it in context. There's a 45-year-old female with no significant past medical history. She fell and hit her head skiing. It was witnessed. She didn't have a helmet. She didn't have a loss of consciousness. She's joking with her ski instructor about her fall, but it was a very significant fall. So they followed their rules. They took her to the ski patrol came, they took her to the infirmary, they called the ambulance. While she's in the infirmary, she refuses the ambulance. She leaves the infirmary, essentially AMA, if you can do that from an infirmary, and went to her hotel room. But the ski patrol and ski instructor that was with her was so concerned about the fall that she went with her. So she has this heightened sense of awareness. 90 minutes later, the patient says she's not feeling good. They call an ambulance at that time. It comes in 10 minutes, but during that time, she has headache, she has nausea, she has vomiting, she's still conscious. They take her to a local hospital, which is about 30 minutes away. By the time she got there, she arrived 4 hours post-injury. At that point, she's in coma. They transfer her to a tertiary center for traumatic brain injury. She arrives there an hour later, so now she's 5 hours post-injury. And prior to even getting there, she herniates and she becomes an organ donor. So these are the patients as providers that will keep you up at night, like, what didn't we do? What could we have done? This is a very familiar case to all of you. This is Natasha Richardson. So when you look at the headlines after her accident, it says tragic delays after her fatal fall, despite best efforts with the EMS. She did speak to her husband at that time, and he said that she said, "Oh, darling, I've taken a tumble in the snow," and that's how she described it. So here you have a person, GCS of 15, you have people around her telling her, let's just go, get you checked out, and she's denying it. So when we look at her, we know, and I was here for part of the session this morning, you know, time is brain for all sorts of trauma. Getting people not delaying treatment improves their outcomes. So from a brain perspective, time is brain. And we could have probably mitigated that primary brain injury by preventative strategies such as having a helmet. She didn't have one on. But when we look at just this very simple schematic of secondary brain injury, we didn't prevent the primary brain injury, but we want to prevent those secondary brain injury processes. So we see increased tissue pressure after the primary brain injury because those cells release water. In the brain, we see increased intracranial pressure. If we don't have a good mean arterial pressure to support the brain systolic pressure, we'll see a decrease in cerebral perfusion pressure. When we see that, we see a decrease in cerebral blood flow. If you don't have enough blood flow, you decrease their oxygen. It causes ischemia. It causes cells to break down. They release more water, and the cycle goes on. So we really want to interrupt that cycle when we haven't been able to prevent the primary brain injury. We know that there are certain factors contributing to secondary brain injury, and these factors are very well managed by our EMS system, and we try to manage them well in the hospital. We know that these systemic factors of hypotension, hypoxemia, hypercapnia, so changes in their CO2, all increase morbidity and mortality in severe traumatic brain injured patients. Furthermore, the longer they're in the hospital and all of these other secondary systemic factors come into play, along with delayed brain hematomas, increased ICP, cerebral edema, hyperemia, subarachnoid hemorrhage, all of these things contribute to secondary brain injury. So what do? Here you see a guy holding a canary in the coal mines, and canaries were used in the coal mines in the 1800s. Canaries are an interesting bird because not only when they inhale do they have oxygen, but when they exhale, they also have oxygen that's stored. So they are very sensitive to changes in their environment. Just like the canary is sensitive to changes in the environment and can alert the coal miners when there's carbon monoxide in the mine and that they should take action, the providers, whether they're EMS, nurses, physicians, who has ever taken care of these moderate traumatic brain injured patients, really have to be hypervigilant. So we know that there are certain risk factors that increase your morbidity and mortality. Age, the older you are, the lower your Glasgow Coma Scale in that moderate TBI spectrum, so 9s are worse than 12s. Delays in imaging, we see that with Natasha Richardson. She had significant delays, which ultimately were fatal. CT findings, so we really rely a lot on our imaging right now as far as what's going on in the brain, so utilizing those strategies to care for these patients. Delays in surgical management. Sometimes the science of surgery is the art of surgery, so depending on the provider, there can be delays. Depending on the location of where the patient ends up and who's available, there can be delays, and I'll show you a case of that. Whether or not they have any sort of coagulopathy. So what we know from recent literature is that patients with traumatic brain injury have platelet dysfunction. They can have normal platelet levels, but those platelets will not work appropriately. Additionally, we have patients that are coming in on all sorts of medications that cause coagulopathy. So all of those things combined can increase your risk for advancement from your moderate TBI to something more significant. When we're looking at these patients, we have, our goal is, prevent and correct secondary brain injury insults. And we have tools that help us use the research for assessment and management. And one of those tools are the Severe Traumatic Brain Injury Guidelines. We know from the TQIP guidelines that we're going to do our EBCs. We're going to assess for associated injuries. But we're also going to look at the Glasgow Coma Scale. We're going to see where they're at. And we're going to do serial neurological examinations. We're going to use our CTs, MRIs, all of our imaging, and we're going to triage appropriately. The serial neurological examinations become a key component for care for any traumatic brain injury, but specifically for moderate traumatic brain injury, because we want to be like those canaries in the coal mines and pick up the subtleties of the neurological examination early so that we can implement strategies that can hopefully prevent secondary brain injury. Once they decline and they're considered severe traumatic brain injured, we want to treat appropriately using the Brain Trauma Foundation guidelines. So when we look at an algorithm that looks at moderate TBI, the algorithm essentially is like severe TBI. There's a circled area there that is specific for moderate TBI. It talks about whether or not they're normal, meaning is their GCS 15. If they are, admit them to the ICU, monitor their neurological examination closely. If it worsens, and they define worsening by a GCS of 2 points or more decline, then you want to take them to CT again, and then you want to start to implement the severe traumatic brain injury pathway. So as we look at pathophysiology that lends itself to moderate TBI, and we talk about types of traumatic brain injuries that we see, we talk about Natasha Richardson. She had an epidural hematoma. And we see that in 8 to 30% of moderate TBI. The mortality is about 10%, and she had what they describe as that lucid period, where she's awake, she's alert, her GCS is 15. Most epidural hematomas are located in the temporal parietal area. And what it is, it's a stripping of the dura from the inner table of the skull. So it peels away from the skull, and you bleed into that space. And you can see that on that top cartoon up there where it's an epidural hematoma. What you also notice is that on the bottom left is a skull. You should have a high suspicion of epidural hematomas or associated injuries if a person says that I hit the side of my head, because your temporal bone is your thinnest bone in your head, and underneath that runs the middle meningeal artery. And this is the most likely culprit for epidural hematomas. It's rare in the elderly due to adherence of the dura to the skull, so it gets very sticky and it doesn't allow for that potential space. But the problem with epidural hematomas is that mass effect can be dramatic and evolve rapidly. So that's essentially what we saw happen with Natasha. 90 minutes after her fall, she is getting signs and symptoms of increasing ICP, headache, nausea, vomiting. So we want to deal with epidural hematomas rapidly. They are considered a neurosurgical emergency, and they should be evacuated. And the recommendations are that all epidural hematomas of more than 30 milliliters, regardless of GCS, should be evacuated. If they're in coma or they're having pupillary changes, they require immediate evacuation. The non-operative ones, and these are recommendations, they recommend serial CTs in the ICU if their Glasgow Coma Scale is above 8, if the epidural hematoma is less than 30 centimeters cubed, if it's less than 15 millimeters in thickness and there's a midline shift less than 5 millimeters and there's no focal deficits. I'd like to talk about that non-operative recommendation because this is a person that keeps me up at night. We had a 17-year-old skateboarder, came into the hospital, and he fit the bill for the non-operative recommendations, had a temporal epidural hematoma. We monitored him in the hospital for 7 days. He was stable, walking up and down the hallways, completely fine. He went home, and 2 days later, he was dead. His epidural hematoma had rapidly grown, and he had herniated. So when we talk about recommendations and the art of taking care of these patients, it is a team effort, and it requires a lot of conversation. If you look at this CT scan that's on the board, what you see here is a 15-year-old girl who also had an epidural hematoma. She was in Mexico on one of those banana boats with her family, fell off. She was one of 5 siblings on the boat, hit her head in the water, had an immediate headache, was on a cruise, was from the Phoenix area. And so they took her back to the cruise ship where she proceeded to have similar symptoms like Natasha. They took her to a clinica in Mexico where she coded. And they had a general surgeon there. He was able to take this small craniotomy. You can see the flap. I'm sorry, I don't have a pointer. But you can see where the white goes around the brain where there's that opening. That's a small craniectomy. You can see brain that's already herniating out of that opening. But he evacuated a 300 milliliter epidural hematoma, which is essentially the size of a can of Coke. Saved her life. She was flown to St. Joseph's Hospital where we took care of her. On the middle screen, on the right side of the middle screen, you can see a bigger opening in that craniectomy, and you can see that white blood, that white streak that's going from the right to the left inside her brain. Because it wasn't a neurosurgeon and she was in a clinic, that's the drill bit that went into her brain. So she developed, you can see the back part of the brain, there's a darkened area where she developed a stroke from that area. She took a lot of energy to take care of, but young brains heal. She ended up going back for a bigger craniectomy, a strokeectomy. She had ICPs of 80. But after 21 days in the ICU, she woke up. She was able to use sign language to talk to her family, and she ended up going to rehab. Subdural hematomas are another challenging moderate traumatic brain injured patient. We see this is a higher volume of patients that we see in moderate TBIs. 30 to 50% of them have subdurals. The subdural is located between the dura and the arachnoid space. This is crescent-shaped, and unlike epidural hematomas where you have things that kind of dam them up, subdurals can go all across your your brain. They're usually unilateral and supratentorial. They can be associated with contusions, and when we see subdurals with contusions, we know that they've had a fairly significant mechanism of injury. The elderly are very susceptible to subdural hematomas just because of their fragile vessel walls, because of the falls, because of their antithrombotics and anticoagulants. And we see a higher mortality in the elderly than we do in the younger population. We also see a higher mortality if they have a lower GCS and or if they have other systemic injuries present. So here you see a picture of the dura removed. You see a thick clot of subdural hematoma, and look what it's laying right over, the top of the brain. So as we talk about subdural hematomas and management of them, they are a very tricky thing to manage at the bedside. Surgical evacuation is recommended regardless of Glasgow Coma Scale if there's a thickness greater than 10 millimeters or midline shift or brain compression greater than 5 millimeters, or if they're comatose. We monitor our acute subdural hematomas. Some will let liquefy and we'll do a burr hole evacuation after 7 to 10 days once the clot liquefies. Some of the real special issues for subdural hematoma at the bedside is that they're very susceptible to having post-traumatic seizures, and that's because of the cortical irritability from that clot laying on top of the cortex. So they may have a decreased level of consciousness and be having subclinical seizures, or they may have focal motor seizures. So we're very astute at monitoring these people, and we have a low threshold to put them on a trend monitor. Cerebral contusions are the last disease state that I want to talk about for moderate traumatic brain injury. They're present in half of all moderate and severe traumatic brain injury. We see them when there's a deceleration injury, and we have this conversation of a coup contra coup. They're dynamic, they're large, they can expand, as evidenced by this guy that came in last month. So this is a 73-year-old guy that fell off his ladder, was on Coumadin for a DVT, and you can see on the left side of your screen that he has that white area at the top of his brain is contusion, and you can see some little dots on the right frontal part of the brain. He came in as a GCS of 15. What you don't note here is that he did have a subdural hematoma, and he also had some traumatic subarachnoid hemorrhage. So automatically, his risk factors are increased. Over the course of the next 4 hours, he became more and more lethargic. You can see where that bruise on the brain now has expanded. So if you look on the top left, that is pre-op. On the top right is post-op, as much of the hematoma was evacuated as could be. At this point in time, the guy had a right hemiparesis and was aphasic. So he did not require ICP monitoring. We continued to monitor his labs, and he ended up going to rehab over the course of the next week. So contusions have a special pathophysiology. There's this core initial zone of injury, and then there's this pericontusional or around the core of injury. What we know on PET study is that it is not due to ischemia that we see this advancement or blossoming of contusions. It's due to decreases in cerebral blood flow. And the hypothesis is that this pericontusional area perhaps is injured during the kinetic part of the trauma, and the bruise itself evolves out gradually and moves outward to necrosis and causes changes in the cascades and the coagulation in the pericontusional area. And this can lead back to that simple schematic of secondary brain injury that we saw at the beginning. Contusions, we call it blossoming. The average rate of blossoming or progression is about 45%. There are different progressive predictors, including size, severity, coagulopathy. If a contusion is present on admission on the first CT, they're at high risk for blossoming. And it's present in about 20% of moderate traumatic brain injuries. We see it mainly in the frontal lobes, and with frontal lobe damage, you have cognitive impairment. So it presents a special challenge for families and conversations with families. Here you see a patient with bifrontal contusions, and this is a special challenge because we know that these patients are most likely going to have fairly significant cognitive deficits. We had a young gentleman that had an ATV accident in June, 15 years old, and he had bifrontal craniectomies because of bifrontal contusions after a long conversation with his parents that he would probably have permanent neurologic injury. He came back in, he went to rehab, he's actually doing much better. He came back in for his craniectomy or his bone flap replacement. And following that procedure, that is not a benign procedure, he had epidural hematoma formation, the bone flap came back off, he recovered from that and the bone flap went back on. So it is a special challenge for this population. From a medical perspective, we'll manage their serum sodium, potassium, and serum osmos because they're at risk for SIADH and DI. And we see death due to respiratory arrest, coma, autonomic changes. So what do we do with contusions? We watch them. We may watch them up to 2 weeks in the ICU, and that's what the literature supports. We're really assessing the neurological examination, and we're making sure that the subtleties of the neurological examination are passed on. We're getting CTs and labs. And then we're starting to consider using thromboelastogram or TEG studies. TEG is a laboratory test that does not correlate with PT or INR, and it demonstrates the interaction of the platelets in the coagulation cascade. And it allows for monitoring for all phases of the hemostasis, including clot development, strength, and stabilization. So as more and more information comes out about TEG and severe and moderate TBI, this may be an opportunity. For patients that become or show signs of severe traumatic brain injury, we will do ICP monitoring if there's mass effect. And as I said before, decompressive craniectomies and craniotomies are considered in the following patients that are following commands but have cerebral edema. And we're really only aggressive for those patients that are at risk for death. So what is the future? There are predictive models out there that people are trying to do to see which patients are going to do well after traumatic brain injury. One of them is the impact calculator. It was done based on the CRASH trials. It's been found to be good for large cohorts of patients, but not for individual patients. What about biomarkers? So they're shown to be such as S100 beta protein. They're shown at the bench to be elevated in severe traumatic brain injury. And elevated concentrations are associated with unfavorable prognosis. But we don't use those. Those aren't routine at the bedside. Advanced neuromonitoring. There are many centers that use different types of advanced neuromonitoring, but the value of the advanced neuromonitoring really is the art of the people that are taking care of those patients. So I've been to centers where brain tissue oxygenation is their canary in the coal mine because they're picking up changes in hypoxia earlier, and as we know, hypoxia increases your risk of secondary brain injury. So their clinical parameters, they offer complementary information. They can help individualize care by doing targeted and goal-directed therapy with the thought of reducing secondary brain injury. Do we need to look at reclassifying how we look at traumatic brain injury so we are more hypovigilant? This would take a worldwide initiative Do we need to look at potentially severe traumatic brain injury? And those are for patients that are GCS of 9 to 10 with a normal CT scan, or a GCS of 11 to 13 with abnormal CT scans. So the future of talk and die, can it be talk and live? I think it's going to take much more conversation. As providers, wherever we are in the continuum of care, we need to continue to sound the alarm. I talked to a nurse that was involved with the Natasha Richardson case, and she said that one of the things that they really struggle with in communicating at the EMS level is kind of that sales spin on you can die from embarrassment. So whatever that is, or however you need to communicate the science behind traumatic brain injury to get them to their next level of care for evaluation, that becomes important. So we're all the canary in the coal mine. We do need to sound the alarm. We can deduce those patients with high risk for deterioration. We know who they are. They have risk factors. We can detect subtle changes in the neurological examination and communicate those changes immediately. And we can mitigate secondary brain injury through timely medical, nursing, and surgical management. So with that, I'd like to thank you for letting me speak with you this afternoon. Answer any questions.